In the United States, in Latin America, the one you amputate, 40% die in the first year. I have it documented.
There is definitely a gap between what we believe and what most vascular surgeons believe. It went badly for me because statistically you have a solution with a 70% success rate. The chances of being in that 30% are high, possibly also due to lack of experience, right?
When I decided to pursue a peripheral topic, my mentor at the time told me that's professional suicide.
If you're going to ask a question that doesn't move the needle, that just complements what's already been done, who cares? I don't care.
Two vascular surgeons walk into a bar and come out with a podcast. We are talking everything vascular and not. Welcome to the Life of Flow podcast.
Good morning, everyone. Today we have with us Dr. Fabiani joining us directly from Monterrey, Mexico, and on his way to Argentina for a congress that sounds absolutely spectacular, set among vineyards. And today we're going to talk about a project that Alejandro both formed and led, which is of great interest to us, and it's related to venous arterialization. So Alejandro, I'm going to hand the floor over to you now, so you can tell us what the project is all about and what we'll be keeping an eye out for.
I'm truly honored to be sitting here with you again and with Miguel. I genuinely feel so very honored that you keep me in mind. So to not make a long story out of it, how does this all begin?
I'm certainly not a detractor of anything.
But I like things to be clear. And I've discussed with Miguel and with many other people about venous arterialization and the definition of what a no-option patient is. What I told, we don't call it no-option CLTI. And the reality of the situation is that, in my opinion, this is a fundamentally flawed definition. And with many other vascular surgeons, we have discussed countless times that we simply do not see that 15% of no-option patients. I mean, we believe that it is much less. And then I started talking to people, and what is no option for you? What is no option for you? And obviously, there wasn't a clear definition.
Just quite spontaneously, I actually went ahead and submitted an editorial piece, completely unsolicited, to the Journal of Endovascular Therapy.
And honestly, with very little hope that it would actually be accepted. And to my surprise, they replied within a week saying they wanted me to add a table with some specific details, but that they were extremely interested, and within a month it was published. And so it was an editorial where I was calling for action, for something to happen. I mean, if you're denouncing something or saying that something is wrong, you really have to do something about it. I learned that lesson once. It wasn't that many years ago, from a researcher. I believe he's a Brazilian cardiologist, who works extensively with anticoagulants. And so while I was speaking with him, I said, well, but for that, there's no, actual evidence. Then he told me, look, when you happen to find something for which there is no evidence, that's your opportunity to actually go and make the evidence, because it's incredibly simple to just say there's no evidence. If there's no evidence and you are interested in it because you truly need it, then you must create it. Obviously, attempting to create concrete evidence for a mere definition is something quite impossible. So I had a discussion with Jos Vandenberg, who is a very good friend of mine, and he also shares with me that very same feeling of a definition that is not at all clear. And we both agreed what could be better than to try and create a consensus. I spoke with Ana Hitadua, and she became quite enthusiastic too, and we thought about trying to build a consensus. Obviously, when you're talking about consensus in these kinds of situations, you're going to think of Delphi, the Delphi methodology, and we started working on that. And each of us invited people. I'm sure I invited you. Miguel invited a couple of friends, until two people appeared, Lorenzo Patrone and Agus Isa. Those guys are the most media savvy in vascular surgery or in vascular pathology. They have a huge network. They're friends with everyone, and right away they're generous. They're good people. They're friends. Immediately they opened their schedule. They started inviting people. Agus shared his contacts with me so I could invite them, but a wave of interest was created. And a Delphi consensus, which normally brings together 30 people at most. For this one, I believe we have over 160 participants. And when you take a moment to look at the names of the individuals who are taking part, you'll realize that they are the absolute top experts from all around the globe.
So you really placed a significant amount of value on this consensus. I think it might be worthwhile to briefly explain, because not everyone who is listening to our show or watching the podcast fully understands what a Delphi consensus is. For those who don't know, when you have to define something, if we're 5 people sitting at a table and say, okay, let's make a decision, it doesn't matter if it's a definition or whatever. Obviously, there are many biases from the speakers as to who is right. I mean, you don't do it intentionally. Normally, it's just you somehow prioritize people's responses based on their experience or what you consider to be their expertise on a particular topic. The ability to communicate also plays a very significant role. There are people who are incredibly intelligent, have a wealth of knowledge, but they don't know how to communicate. That person, perhaps you're missing the chance to hear their thoughts or their ideas because they don't express themselves well. So there are so many variables involved, or another, because he's the boss, so everyone thinks they must listen to him. This Delphi concept was invented, which means all the responses are anonymized. I mean, you don't know who provided them. And for example, in this case, which is a definition, we say, well, we make statements to avoid constantly reconvening, right? But you make 3 or 4 statements, you send them to the group, and everyone responds. That then enters a database, which is immediately anonymized. Each of those individuals needs to indicate their level of agreement or disagreement with that statement using a scale from 1 to 9. 9 means I am totally in agreement, and 1 means I am totally in disagreement. Understand? When this is predefined, the usual cutoff point is 7. So everyone who rates 7, 8, or 9 is considered to be in agreement. Those who rate 6 and below, or rather 7 and below from 1 to 6, those people are asked to propose what they would change in the document to be able to agree. So what you're doing is working, that is to say, the core group, in this particular case, Anahita, Chos, and myself, what we were doing was working with those responses that fell below a score of 6 in order to reformulate the statement by incorporating all of those changes that the people are proposing. Obviously, you can't tackle every single one of them. Instead, you begin to search for what carries the most significance, and you continue doing so until, and I must emphasize, this is a matter of convention, a pre-established definition, until you achieve a point where 70% or more of the individuals responding are scoring above a 7. That's how a Delphi consensus is conducted. So in that way, you don't know who responded in favor or who responded against, but you keep modifying the statement based on the suggestions received. Sometimes it can take you 3, 4, 5, or even 6, rounds. We fortunately managed to finish it in just 3 rounds, I believe. So that was good because it was actually something very, very focused, because first there was a previous definition made by Kim and Snyder, I believe, that it was good, it was solid, but nobody ever really took it into account. And so first we asked ourselves, are we truly content with that definition, or do we need something more?
And to explain to the entire audience what exactly was that definition. Well, look, it's a framework that, speaks very vaguely about these possibilities. And the truth is, it hadn't really been adopted.
So the first question that was asked in the consensus was, should we start adopting this, or do we need a new definition? And that right from the very first round, everyone was in complete agreement that we urgently needed a fresh new definition. And that's precisely where we began the process of constructing that new definition, which in actual fact, what this definition aims to do, it's not really about creating something entirely new, but rather to objectify and clarify what we all inherently understand and express. So you're saying desert food. What exactly is a desert food to you? What is a desert food to me? What steps did I take to arrive at the conclusion that it is, in fact, a desert food? Because if I performed a CT scan with incorrect timing, well, for me, that's a desert food. And then you go back and check, and that CT scan was actually poorly done. So you're not really in it either. The whole point was to try and search for a way to make objective all of those aspects. And so that's precisely where the concept of no option and pure option was developed. Okay.
I don't know if you wanted to. Yes, let's go a little deeper into what I was saying. For me, the definition basically is that is what's called middle artery cosenosis or this sad disease that Ferreres did mention basically after the midfoot. I mean, if I see that there are no named vessels and I have a wound that's not going to heal with just wound care, that it's going to need revascularization, well, then once I see that pattern with the calcifications in plaque and then the what we observe in the angiography, well, then that is already a desert foot. And for me, I think that the patient is really going to benefit from a naturalization procedure instead of a standard angioplasty, which quite frankly probably won't last for a very long time.
Somehow, obviously, the definition that I'm about to share with you, which isn't a phrase but rather a process, aims for that, right? It seeks for us to all be in agreement and not just I think it is. I insist, I'm not against anything that could possibly save a limb, but I truly believe that labeling it no option really opens up a whole lot of possibilities, of which the very last one should be amputation. So if in a no option scenario you want to try stem cells, then by all means go right ahead. If you want to give prostaglandins in a no option case, go ahead, because I have nothing better to offer than amputation, right? Let's see what just came in.
Yes, someone has to work.
Yes, you two are a couple of lazy good-for-nothings. How are you doing, guys?
Look at how lazy he is. I have to go to the hospital, and this still takes up my time. 1,000 things to do.
Yeah, I know that. The only one who's actually lazy is Lucas.
I've actually started working a little bit more
yes,
again.
right.
My sabbatical period has officially come to an end.
All right, very well. My apologies, right? I'm just finishing up my cases and I'm at your service. Give me a quick summary of where things are going.
Well, we introduced the project. We then introduced what constitutes the definition of Delphi consensus, and we are now beginning to examine what exactly was the prior definition of the no option patient, and we are discussing that topic and elaborating on it.
I was explaining to him that the entire fault is yours, Miguel, because at some particular point you stated that you drop, I truly believe there's 15% of patients with no option. And I responded that has absolutely never happened to me in my life. And from that very moment, I've begun to discuss these specific issues everywhere.
No, look, let me just tell you this right now. This happens very frequently with older folks who always tell me that, because I distinctly recall being at the BIS symposium in a no option session. And Dr. BIS then stood up and he said, Miguel, your 15% no option statistic, I find it quite ridiculous. In my entire career, perhaps only 1% of my patients were no option. I told him, yes, Dr. BIS, with all due respect, the point is that the patient from 30 or 20 years ago is not the same patient we see today. At this very moment, the patient presenting with severe diabetes with kidney failure undergoing a renal replacement therapy exhibits a totally and completely distinct pattern. Well, that is to say, we used to see patients from the Second and First World Wars with orthoiliac and femoropopliteal disease secondary to tobacco, but it wasn't the 45-year-old patient who has no outflow. So I truly feel there's an absolute shift. I've personally witnessed it throughout my career. I'm already entering the veteran stage of my career, but I've accumulated at least 25, 20, or even 30 years of experience in this field, and I've witnessed it with my own eyes. I mean, for me, an iliac occlusion is something I encounter perhaps once every, I don't know how many cases, but a diabetic patient presenting with tibial vessel disease and Bilodianco, that's something I see on a daily basis. So I feel that there is a complete transformation.
We also believe that there is a change, and there is also a geographical change. I mean, if I were to go to the Mendoza Congress right now, they would be discussing superficial femorals for hours. I don't remember when I treated, today I saw a patient who explained to me he had a superficial femoral. But let's say for me, it's the exception. For me, it's all below the knee. But because Mexico is a country full of diabetics.
And yet, Alejandro, and even so, I must ask you, please forgive me for interrupting you. And even so, what do you perceive is the reason that we are seeing more BTK cases today? Don't you feel that a significant 15% of those patients truly have no other viable option?
I think a higher percentage has no choice but an economic one here in Mexico. But no, not an anatomical one, right?
But anatomical? Anatomical.
Look, I have a problem. My practice is very biased because I work in a place where people are rich. So the people there are very well taken care of. So I don't typically see the patient who has had diabetes completely untreated for many years, who arrives with a creatinine level of 4, and who didn't even realize that urinating was a normal part of their daily life. So that's not something that happens to me. In
Yes.
Argentina, I worked for 20 years or even more at CIMIC, that is to say, from 1990 until 2013, and it is one of the largest dialysis centers. It is a very large kidney transplant center. For many years, I was biased towards the pathology of the immunodeficient, like transplant patients and those with chronic diabetic kidney failure. But the truth is, I didn't have such a high number of no option cases. Maybe things have changed. Maybe people live longer now too.
And also, it depends entirely completely on the geography. I agree with that. And that's why I believe this is so important because, especially here in Texas, Miguel, Austin is just 2 hours from San Antonio, and yet they are completely different populations. I would say that in San Antonio, probably 10%, 15% perhaps is a little too high, but definitely 10% of the patients should be considered for an arterialization. Austin, it doesn't even reach a 5%. So I imagine Dallas isn't much different, but if we go below what the
And
actual figure
Monterrey
is,
is what Alejandro says. For me, Monterrey is like Dallas, right? I mean, Monterrey is a city that's just super wealthy people. They have some spectacular stuff, but there are also people, as Alejandro says, who don't even remember to pee. On the other hand, I feel that here I have a lot of patients who come to me for second and third opinions, and they come with a complete bias. Today, I was having a conversation with a good friend who, at this moment, unfortunately, is caught up in a medical legal problem here in the United States. He was asking me, Miguel, how many major amputations do you perform annually? I told him, I do a whole lot, unfortunately. And the reason why this is the case is because my practice is where we have to send patients who have absolutely nothing left. And then colleagues right here in Houston send me patients and tell me, look, I don't know if it's really worth it, but I'm going to send them to you for your opinion because the family wants that last glimmer of hope. And when I see them here, I tell them, you need an infracondylar amputation. No, it's not the end of the world. I mean, many do very well and end up rehabilitated, but it's truly, truly difficult when that's your practice. So I think the effort Alejandro is making to create some degree of structure is very important. It's very important because what for me is 50%, for him it's 10%, and for you it's a 5%, Lucas. And so to generate some structured consensus, at least in the definition, I think is very important.
Yes. Look, what you're trying to say is that Monterrey is essentially a Dallas. I don't remember. I went to give a talk at a conference in Europe, and I was discussing the cheap toolkit for revascularization, comparing it with the full one and the results. So why? I mean, it's not ethical to have a cheap toolkit and the full one, right? So I had to explain that reality. Monterrey, where this hospital is located, it has a GPI, as they say, the gross income. That's the same as Monaco's or Luxembourg's. But just 20 minutes from here, it has a per capita income that's exactly the same as Kosovo's.
I mean, that is the disparity, yes.
And you, Alejandro, where do you fit in?
I was lucky to land in Puerto Rico.
No, it's actually a real stroke of luck. It's genuinely a real stroke of luck. Yes. I mean, I leave my work feeling less anxious at the end of every day. But there is a foundation here at Tech, and I'm constantly requesting more funds, and I meet with the Secretary of Health. I mean, they brought me to Mexico theoretically for the aorta, and I said, wait, why am I wasting my time on the aorta if they are cutting off everyone's legs here? So I dove headfirst into what I had also been doing my entire life, but back when I was young, revascularization wasn't considered, a very appealing field. Do you understand? I mean, we were doing it every single day. We were performing bypasses. I mean, that was just part of our everyday work. But you wouldn't show that at a conference because nobody was interested. Everyone wanted to see aortas, wanted to see, or perhaps you didn't quite get to live through that particular era, but in those conferences, they only talked about aortas, not lower limbs.
Absolutely. Yes, no, I remember it very clearly because I recall that when I decided quite early on to specialize in peripheral, I remember that my professor, my mentor at that time, he told me, it's professional suicide. He says to me, no, that is professional suicide. No, don't do that. Don't be so foolish.
We did it every day. I mean, it was just natural. I mean, it's like for many years, no one would show they operated varicose veins. Today, in all congresses, the most popular sessions are the venous ones.
Yes. But
sorry, yes,
let's see.
go on.
Could you tell me a little bit about the
the outcome, right? I apologize. You've already discussed what a Delphi is, how it functions, and what the underlying reason
Yes,
for
we've
it
done that.
was. Now, tell me a bit about how the experience of the process of gathering all these people from around the world actually went, and then let's dive straight into the results.
Look, the process, as I was telling you, was very much hand in hand with Lorenzo and Agus, who are, the most popular guys in the world. And they opened up their schedules for us. And a number of people we truly hadn't expected ended up joining. So that made it very rich and interesting because you see the names of those people and they are true personalities. So that gives, I believe, much more value to the idea of consensus. It would have to. Let me just get this open here. All right. So, as Miguel and Lucas and I were just talking about, these were the participants in the study 164 specialists from more than 150 different centers representing 30 countries and all 5 continents. You see, the average experience of those who participated was 20 years. More than 6,000 patients were treated annually by all of them combined. Over 5,000 publications on the shoulders of that entire group. This, I mean, solid, absolutely solid.
3 of the 5,000 were mine, no?
We're going to begin the very first round and then we'll move on to the definition of desert food. Let me just check if I have it here. This is presented in steps. Well, to claim you have a desert foot, you'd obviously first perform an ultrasound, a CT scan, an MRI, or something similar, because obviously, if you have, as Lucas mentions, a named blood vessel in your foot, then it's no longer a desert foot, is it? When you did that particular thing, and if you weren't lucky, then you go for digital subtraction angiography, as we all do, and we set the exposure there for more than 20 seconds because obviously it must happen to you too, that you get patients who say they don't have any distal vessels. Well, you do an arteriography with prolonged exposure, and yes, distal vessels appear. No, I'm not reinventing the wheel. And obviously, you should try to perform this injection at a site that is as distal as possible, but one that still offers good collateral flow. What I mean is, if you're going to access the superficial femoral artery all the way down and it's completely occluded and you don't apply sufficient force for the contrast to ascend to the deep femoral, then you most likely won't visualize anything distally. In that case, just do it in the common femoral, not where the vessel is occluded, and even sometimes try to pass a guide wire through an obstruction and do a more distal shot if you had an isolated popliteal or a vessel like that, to try to find some distal vessel. Once you've done all that and still can't find a distal vessel, you must attempt at least one endovascular revascularization. This effort must be made with the appropriate materials and by the most suitable individuals. Now, obviously, how exactly we define appropriate or right, that's something we can't fully specify. But the materials, of course, yes, they must be specifically dedicated for that purpose, and you absolutely need an operator with extensive experience in distal revascularization. So then you would give it the label desert foot. If once you have gone through these 3 steps, you haven't managed to find a distal vessel. This is essentially the same concept, but it's presented in a diagram where in the first step you don't have any imaging, and then in the second step you don't have with angiography, you're not able to achieve revascularization. So at that point, you already perceive it as a desert foot. What makes these current changes different from previous definitions is this new approach of establishing a minimum time and using multiple injection sites. It's not simply giving one injection and then saying, that's it, I didn't find anything. And to find the suitable vessel, as we were just discussing. And the other thing is the attempt at revascularization. That's the only thing that changes from previous definitions of desert foot. This is the first round, and we're talking exclusively about the anatomical aspects, which is, desert foot and the absence of an autologous duct, right? A lot of people, if they don't have a suitable vein in that leg, they often say that's already a patient who doesn't have an autologous conduit. The idea of this whole group is that we need to be a bit more incisive and obviously look in the lower limb, either the same or the contralateral one. Always keep in mind the small saphenous vein, which is a really excellent vessel for bypasses. Yes, it truly yields very good results and remains patent for a very long time. So obviously all of this is mapping with ultrasound, right? It's not like you have to be exploring the patient. Yeah, but you do a well done mapping with ultrasound. You see if you manage to obtain a necessary length in the upper extremities, even in both of them. And finally, what you were mentioning, the composites or spliced ones.
There are many options available. You can perform a splice vein procedure. You can also create a composite graft. You can even consider, which are not always the best options, but a cryopreserved vein, a cryopreserved one. For me, what really determines if a patient is a candidate or not is that they don't have an outflow, meaning that you don't have a named vessel. I mean, for you, it's all about the outflow, and I agree. It's entirely about the outflow, yes, with you, but this will give us the room for the poor option.
So obviously, as you can see here, we began to explore different alternatives. And here, as you can observe in the bottom right-hand corner of the chart, we considered using prostheses because in fact, these prostheses have demonstrated up to a 60% permeability rate per year, which really isn't too bad at all. Well, cadaveric ones. In my younger days, I performed many cadaveric procedures with arteries, and they didn't turn out badly at all. It's just that after about 5 or 6 years, they tend to degenerate and become aneurysmal. And obviously, cryopreserved grafts, which are not available everywhere in the world, but it's clearly a very good option to consider. So there's no need to despair or get discouraged by the thought that if you don't have the saphenous vein from that leg, you won't be able to perform a bypass. So once again, 3 steps, and you need to keep in mind the alternatives, right? Before I start talking about that you don't have a glass. And then someone proposed during that first round, as I was explaining, among that percentage who aren't entirely in agreement with the definitions, they suggested that a TNM style classification be created, a TNM type. That was Miguel, who absolutely loved the TNM system. I don't know, because they were anonymized. I don't know if it was Miguel or not. It must have been Miguel because he's told me that like 500 times already. So we ended up summarizing the TNM as the A for anatomy, the B for biology, the R for patient risk, the F for functional status, and the C for contextual modifiers. Obviously, each of them is quite extensive. It's best to read it later once it's published, but we didn't want to duplicate our efforts. Obviously, the anatomy and reconstructibility aspects, those were already covered in the first round, including how the desert foot was defined and whether a duct was present or not. As for biology, it's already a standard. There's no point in trying to invent anything when a classification already exists that has shown its effectiveness. Regarding patient risk, I believe the ASA classification is too widely dispersed globally to adopt it. Then the functional status, we'll talk a little bit more about that now. As for the functional status, is when you have a limb that is completely functional. I mean, a patient whom you revascularize and they will go on to lead a normal life. F1 is when the person will use that limb to transfer themselves from one chair to another. They have a degree of ambulation that's quite limited, but they absolutely need their leg in order to move around. And the non-functional refers to that limb which quite obviously won't be of any use at all. Those individuals who are already confined to a bed with their limbs retracted, where preserving it or not preserving it won't contribute to anything meaningful in their life. What we also took into account, which is quite innovative, is what we termed contextual modifiers. These are, for instance, those patients who you know for a fact won't take their medication, who won't comply with any of their doctor's orders or the medical prescriptions given by their doctor in the post-operative period. Or the patient who tells you now, oh, I don't want to be revascularized, I want to be amputated instead. Obviously, against that, there's absolutely nothing you can do, right? So this entire situation, which once again appears quite complex, it's actually quite simple. There are 4 specific conditions that will lead you directly to becoming what we call a no option. The first one is anatomy, which is known as the desert foot. Well, another factor is the risk involved, especially when it poses a prohibitive risk to the patient. Patients who are already in a pre-mortem state, if you were to take them into the operating room, you would essentially be killing them. That's what we refer to as ASAVI. Then there's the patient who, as we mentioned earlier, has a limb that completely lacks any function, so they truly have no other option. Or the patient who, quite simply, doesn't accept the revascularization procedure. So those 4 specific criteria will directly lead you to a no option situation. And then the definition of what would be a poor option appears, which is a combination of a patient who is revascularizable, for example, significant anatomical challenges or extensive calcifications, or even patients who have undergone revascularization multiple times already, and then they become blocked. The situation where you don't have an autologous conduit readily available and you find yourself without a good suitable conduit that's available, and then you're forced to use an alternative option in a patient who simply has no endovascular choice, and you know that their anti-aggregation, their use of statins will be absolutely fundamental so that the patient doesn't quickly occlude. You want them to walk to keep that functioning, and you know the patient won't do it.
So that's what would essentially be placed into the category, of what we're designating as a poor option. And obviously, it's crucial to always keep in mind that this particular information is, in fact, nothing more than a consensus reached by a panel of experts.
I mean, to start off, we didn't invent anything new, but simply organized what was already there. And moving forward, this absolutely requires validation. Yeah, because this is genuinely what we believe to be true. I think it is truly fundamental to carry out a proper validation of this classification by carefully examining the actual results.
So, I'm not sure, but I'm going to ask a question here. Has any of you ever performed an arterialization procedure on a patient who has a specific target vessel, but who simply doesn't have any other viable option for an autologous vein or a SS splice vein or anything similar to that?
I've never done it myself.
Why not?
It also really depends a lot on designing. If they have a specific target for a bypass, there's a target, you've no knack. What do you do?
A duas or a splice vein bypass with a splice vein
Useless.
isn't useful for. Clearly, I'd say so.
Oh, even a splice vein. It's no good for anything. It's completely useless. It doesn't last more than 6 months. Well, let's see. I mean, if you want, let's do another show about splice vein conduit. No, it just doesn't compare to a good saphenous vein. It just doesn't compare.
I perform an arterialization.
No, they're just
No,
useless. They're
I've
useless.
had a lot of patients for 5-6 years with distal
But
pulses.
is it really
and with a
with a
bypass that's
cadaverous
still
one?
working? We're talking about cryo here. I think we're talking about two different things.
No. It's cadaveric. I mean, they send you the cryopreserved vein
Cryopreserved, that's useless. They've only used it for kids.
from a doctor who died in a traffic accident. That's good for absolutely nothing. Nothing at all. They all either get blocked or they are aneurysms. They're good for absolutely nothing.
And aneurysms do form, yes, but after 4 or 5 years, not initially. Well, I think we're talking about two different things, because what I have access to here is the cryopreserved GSV, which is completely useless. That lasts. I mean, it's only useful for infections.
Exactly. That gets you out of an infection. But then in 3 months, you have to decide what to do.
Patient who comes to you with tibial disease, they are usually a patient with a very serious MAC. You all have much more experience than I do because I'm much younger.
A patient who has a distal vessel, how many patients where you might have a distal target, but somehow you just can't reach it endovascularly? Imagine the case. They don't have any conduits. You don't have the ability to take it from their arms, let's say. Today with distal punctures, like you all do hyperdistal, right? Because I do the same as everyone, no? PDL or tibial, but you guys do hyperdistal. If you have a good plantar, I know you puncture it from bottom to top and you'll open something. It's exceptional. Yes, the one you won't achieve, right? What I do think, and I truly believe that this group that we have formed, it would be incredibly interesting to really make the most of it, to begin utilizing it for some truly serious work. For example, that specific patient who only presents with a single plantar, I'm a little bit lost on that point. I'm not really sure. What will be the long-term prognosis for that with an angioplasty performed through a hyperdistal puncture as opposed to a venous arterialization? It would be truly interesting to utilize these 1-65 specialists from all around the world to begin conducting well-designed randomized studies on all of this. Why do you claim that venous arterialization is a better option than the very best medical treatment available? I believe them, no, I don't doubt it, no. But it would be very interesting to do a study like with Lucas's cross factor, as we already mentioned. I mean, start looking for more evidence on these topics, because perhaps we learned that venous arterialization is not for the no option patients. This is for a group of patients for whom their traditional revascularization option isn't as effective as venous arterialization. Perhaps venous arterialization is actually better than we currently believe. I see presentations at medical conferences from people who demonstrate that a venous arterialization 5 years later is occluded, but the patient has a lot of neoformation vessels and you don't achieve that with a bypass or an angioplasty.
So maybe we could try and find more evidence.
Yes, I am totally in agreement.
Especially patients who have a longevity where you expect them to be alive for quite some time and they are young with severe diabetes and who already have that pattern of disease. Well, I believe that in those patients, eventually we will start talking about arterialization, or you perform some kind of intervention, but you also administer an adjuvant. I mean, it has a condition where you could open the PT, you could open the IT, but the peroneal artery is already occluded. You do both procedures, you perform the revascularization, and then you do a distal arterialization. I believe that that is a viable approach.
They can be.
The arterialization process causes an ischemic shock, and the majority of patients experience significant ischemic pain in the first few weeks of the postoperative period.
Even though the flow volumes are below 100.
No. The more you are mindful of the flow volume, the smaller that delta is, right? I mean, that ischemic shock. But I think, for example, I'll tell you what I just did. This patient I just stepped out to talk to for a moment is a woman who was sent to me because of a no-option anatomical situation. A very small, isolated segment of the dorsalis pedis artery, but there was nothing there. So I worked on the peroneal artery and opened it up. It had a few branches, but the flow wasn't excellent. I then accessed the anterior tibial artery.
I was able to reach that small little pool. From that small pool, I managed to get into the plantar arch. I opened the anterior and the plantar arch. I know that this lady is going to have a
honeymoon. That is, there will be a honeymoon period where for the next 3 months, the pain will most likely improve. The wound on the first toe will probably look better, but eventually a person who had 30 centimeters of tibial occlusion will experience reocclusion. I came out of the procedure and I told her, look, everything went very well, but I'll need to take her to the hospital in about a week to perform a DBA. And the reason for this DBA is because I need to follow up this short-term procedure with a more permanent long-term solution. So I consider that it is very innovative, but at the same time, I also put myself at risk of a medical-legal problem. Because if someone wants to screw me over, they will, because they'll tell me, I mean, you've already opened it, so why would you do more? But I know that it won't arrive, but I have one, there's a question.
If someone tells me they have
A venous arterialization for a patient whose plantar arch is patent and in continuity with all our circulation, I tell her, that man is a pirate. He's robbing.
Exactly. Yes, that's exactly right. And it's my own.
The concept is not a bad one because we certainly know that it's going to become occluded and you are sparing them from the terrible ischemic pain and the initial loss of tissue from the venous arterialization.
But question that I believe is quite valid in that situation that I've asked myself is, you have a revascularization that won't last very long and you're going to put steel on top of it. I mean, you're going to reduce the blood flow in that revascularization. Will it occlude sooner or not?
Well, no. If it's a distal one, no. Because you're probably thinking that what will get blocked is the long tibial segment.
If you perform the distal venous arterialization, theoretically, it's going to preserve it for you. In my youth, yes, there was a trend at one point. Sorry, not in my youth. When I was younger than how young I am now. Well, there was a trend, to perform bypasses. You do a femorotibial posterior bypass, femoropedal,
Anastomosis
like each side. You do it. You could have removed the blockage. And it was perfect. The bypass would never get blocked, but your foot would rot because you were stealing its vital blood supply.
You were stealing from him, that's right.
We have to do that. Rupture the veins and then ligate the proximal part of the vein.
and to ligate the proximal part.
So that's exactly what needs to be done. Well, Ale, this consensus is significant, isn't it? I mean, perhaps I could ask you a question. Did the consensus really come about because of the increasing number of venous arterialization procedures, or was it actually born out of the necessity to create a structured approach when there truly was no other viable alternative?
Well, that's actually something I was just discussing with Lucas right before you got here. And I have to admit, I'm quite a detractor of your 15%. And
It's good to be a friend, because with friends like me, who needs enemies?
Exactly.
no, it's not personal, Miguel, not by any means. He knows that perfectly well, but it's what we were discussing. We older folks believe that no option isn't all that frequent. So then I sent a letter, an editorial, and remarkably, a week later, they were responding, asking me to add a table that they had loved, and they published it in less than a month. So I said, wow, what I'm pointing out as missing is truly lacking. And I'm not the only one who thinks so. And from there, we built this whole structure and got to this point. So it wasn't the stance against arterialization itself, it was more about the crucial need to identify a patient who truly has no other viable option, and in that specific situation, to offer them whatever treatment they might desire. We were discussing this with prostaglandins or stem cells, compression, anything that you can possibly do to prevent an amputation. Amputation is, as you rightly say,
In the United States and across Latin America, 40% of those who undergo an amputation will die within the first year. And I have this well documented. Out of every 100 patients who undergo an amputation, only 10 are able to purchase a prosthetic limb. And of those, merely 3 manage to be fully rehabilitated.
So out of 100 amputees, only 3 will walk with a prosthesis. Therefore, amputation is not a good solution where you don't have the support of a system capable of providing true rehabilitation.
What are you all doing, Alejandro?
What are you all doing with those patients who don't have a choice?
They're amputating them, but here, as I said, the lack of choice is economic.
No, but let's see. And the non-option, which I'm saying is 15% for you. What is it? 1 or 3?
The question that I have is this. I attended the Congress here in Texas, which I already told you about, Miguel, and you actually went to a debate. I was part of it.
Of which you were one of the directors, but you didn't invite me.
You never want to go. I keep inviting you, and you just get annoyed with me.
Why don't you send Lucas to Mendoza right now?
Oh, yes, that's right. That's right. Next year, I'm definitely going, and I'll talk about all the arterialization you want. But I went to this debate for and against arterialization here in Texas from the Vascular Society here in Texas. When it came to asking a group of 30 or 40 vascular surgeons how many of them truly believed that arterialization was a viable option in the year 2025, which was just last year, I believe only 2 of them actually raised their hands. It's possible that I gave the absolute worst presentation in the entire world.
It's certainly a possibility, I suppose.
But it could also be that there's definitely a significant gap between what we, for example, Miguel and I believe, and what the majority of vascular surgeons think. I believe that most vascular surgeons consider it to be just a fad, something that's merely trendy and nothing more.
I think we need to build good evidence.
But there are randomized studies. We have compiled and aggregated well over 700 cases globally. Who has seen a Mexican pie that ends like an ice cream, like a scoop?
It's just completely red. That extreme granulation doesn't happen. It simply doesn't happen.
No, if we are people who believe in something, then we have to reflect and know what we can do so that more of our colleagues are performing this procedure that helps patients and that more patients can be helped. So no, it's not. No, the problem isn't that. It's not like the other thing is what are we doing wrong ourselves, I would say. And I believe that, well, that leads to Alejandro's question. What do we do with this structure that you've put forward?
Yes. How do we disseminate it, Ale? What do you want us to do? How can we help you now that the consensus has been reached? What can we do? Those of us who believe in the consensus, we support the consensus.
To start, I believe what we really need to do is first validate it, and to validate it, we absolutely have to begin adopting it. I think we should start using the classification. With this TNM, the numbers will appear, all of it.
The one Miguel brought up, the one he proposed, was about
I don't think
doing
so.
the TNM,
Not at all.
right? You're always talking to me about that.
In my mind, I just don't understand why we are giving so much thought to a problem that to me seems so incredibly obvious. I used to say, we're building a consensus of 200 motherfuckers around the world for something that to me is clear as crystal. But nowadays I understand.
Let's make the most of it so everyone sees it clear as day. I don't see it that way.
No, I understand, but I was the dumbass who was in that situation. I don't like this, I don't like this, I don't like that.
If every study you're conducting on all of this, on arterialization or whatever else, you might come up with, on any limb salvage technique that you consider for patients who are no option, and you decide to adopt this, we will then see if that classification is truly valid. And to use the structure of the group that was built specifically for this to generate more evidence, I truly believe that would be absolutely wonderful, because it's a very strong and reliable group.
That's what I wanted to tell you, Ale. What's most worthwhile about this isn't well, of course, the no option message is extremely important, but it's the fact that you managed to bring all these people together. And yes, I know you give Lorenzo and Agus a lot of credit, but ultimately it was you, wasn't it? You're the driving force. You're the one who put it together. And it's outside of a societal structure, which is not the global guidelines. Let's not forget that this is a work It's an international working group. I mean, suddenly, literally overnight, an international working group was created without any specific banner. No, like radiology or cardiology or vascular surgery. It's those of us who want to do things right, and I love it. And I think the most valuable thing in retrospect of this project is that hopefully you'll be pushing us soon. I truly tell you for the next one, because truly there's a very unique value in this intellectual creation. I mean, not everyone brings together 200 brains from around the world. It's very interesting, very good.
And people were truly, truly very, very participative. You know, you're all part of the group. Every time someone proposes something new, many people raise their hands. And I really believe that even if Miguel shows up later saying they're idiots, they still raise their hand.
But I also believe that because people, they work in much more varied situations. You see, some are in the United States, others are in Europe, others are in Latin America, some are engaged in academic practices, while others are not. The data you gather from this type of group is probably much better than from an international working group where everyone is in an academic practice.
This is seriously the real world.
This is the real world we're talking about. Exactly. So we should probably do something about it.
If tomorrow we were to add a database to this post, people would get tired and everyone would just leave. So I think we need to be very specific. And if we're discussing arterialization and looking for indications, perhaps this is a good group for that, or some of them, let's say, finding the niche of what people might be interested in to share data.
I believe that the important thing is to look for the question that moves the needle. A question that truly is something that, like the question that Miguel is asking. Okay, you have a patient for whom you were able to perform a revascularization that won't last very long, whether an arterialization is worth it. That's a question that I really want the answer to. Probably everyone who works on this wants that answer, and many people will be very enthusiastic. If you're going to ask a question that honestly doesn't move the needle, that just complements something that's already been done, then who would be interested? I'm not interested. I already have experience. I pretty much know how to handle that. But what Miguel is doing, that's what I really want to know.
And I'll tell you something. Today, I was on my way to work. A colleague called me whom I had never, ever met in my life, someone from another part of the United States. And he said to me, look, I'm being sued. I'm in a legal bind. They're essentially telling me that I performed too many IVUS procedures. And I told him, nah, how come you do so much IVUS? What does it matter? I mean, IVUS should be 100% of cases. And he tells me, well, there's a paper that supports that notion that IVUS should be in all cases. And so he was calling me, asking if I would be willing to participate as an expert, providing expert opinion for his legal case. And I immediately told him absolutely and completely. But you come to realize that there's this significant need to establish certain protections for us, because I personally use intravascular ultrasound in 99.9% of all my cases. The only case where I don't use it is when the patient is so uncomfortable that I don't have time to work and I want to finish quickly, and that's it. But in 99% of cases, for me, IVUS is strategic. I know exactly what to use, when to use it, where to use it, from where to use it. So for me, I mean, the idea that a colleague under fire because they don't have AI, because there isn't enough data to protect peripheral IVUS, creates the need for the international working group, for example. And I propose this to you, Alejandro. Let's tackle IVUS. Eric Szymanski called me as part of a North American group to validate the utility of IVUS in peripheral arteries. But it's only American, it's not an international study. So for a second project, I'm proposing something that everyone will surely agree on: how to use, when to use, and the clear necessity of using intravascular ultrasound.
Would you actually do that again through a Delphi consensus?
Yes, why not? Why not? I think it's a truly, truly useful tool.
Look, the truth of the matter is that I have opened up this group for you all to put forward any ideas you might have. As a matter of fact, this group doesn't actually belong to me. What I mean is, every now and then, I silence it so that a constant stream of nonsense that just distracts us doesn't start showing up. I think that anything someone can come up with that's truly worth doing, I can make it known that after our conversation, this idea emerged, and that anyone who wishes can propose absolutely anything they might like.
I think we're going to take the consensus on IVUS that Eric Szymanski put together, which is in one way or another biased because it was funded by Philips. Let's create one without any industry involvement, just the 200 of us who are here, and publish a paper. That's the next step. I propose it to you.
I have a service intern, a research fellow, who's become quite an expert that's bothering all of you. So
Perfect.
Fantastic. Ale, listen, it's always a pleasure to talk with you. As usual, you're amazing. I'm at your service. So happy to see you. So happy to see the fact that you keep achieving success. It's truly a pleasure to be your friend and a pleasure to be your colleague. And here at Life of Flow, we are always ready to discuss whatever you might want to talk about because we absolutely love knowing what everyone is doing all around the world.
Yes, and Ale, please let us know when the publication comes out so everyone can look for it.
the truth is the treatment was quite fast and it's all done. It's accepted. So now comes the entire editorial process. I don't know, I'd say about 15 days.
I really think we should broadcast the program once the project itself is officially released and available so that in the episode show notes, we can easily include the download link. And that way, everyone who's listening to this can go and grab the project.
Do we pay ALA for free access?
I suppose I really should pay now.
Really? Look, we'll set up a GoFundMe because it's $2,000. If each person puts in $20, if that's what they usually charge.
Actually, I was asking for it here at the tech.
Well, if he gives it to you. If he doesn't ask Hope, Hope will give it to you. They're damn good, those guys from Hope.
But honestly, do you truly believe it makes a significant difference?
Yes.
I believe that with these kinds of projects, it's absolutely 100% important to pay for the free access because you want the entire world to be able to follow your work. And it's the difference between free access and not. And for a fee of $2,000, no way. But as I said, Hope's gone. It's over. It's done, right?
All right. I really appreciate the invitation, the time and the space. I insist that we keep making the most of this group, which is wonderful. I'm taking the IVUS idea and we'll keep working on it.
Okay then, let's go guys.